Ethical dilemmas in midwifery. A legal disclaimer we put at the beginning of all of our presentations. This information is for general and educational use only. Content is not intended to substitute for professional, legal, or clinical advice. We try to keep our information as accurate and timely as possible, but make no promises and guarantees it works for your local unique situation. As an introduction, ethical dilemmas in midwifery arise from an intimate nature of care and our responsibility towards moms and babies. Navigating these challenges requires both a balance between informed consent, autonomy, and shared decision-making while upholding our family's rights and dignity. So let's get to the basics. What is informed consent? There's a lot of perspectives of this definition, but it ensures a voluntary agreement of care after they completely understand their risks, their benefits, and the alternative options they have. And I very rarely see true informed consent actually occurring because you have a time constraint, you have biases, we may not know all the risks and benefits, and our education on that topic may be limited. So it's really, informed consent is such a word salad because we try to do the best of our ability to educate and give all the options and choices, and maybe they're narrowed and limited because right now we encourage a C-section because the baby's heart rate is down, they're in labor, there's vaginal bleeding, you worry about placenta abruption, and you want to give good informed consent, but you don't have time on your side. You need to say, we'll talk, there's an emergency, we're going to talk about this afterwards, but do you give us consent for a C-section? Your baby is at a massive risk at this point. So there are situations where you're just in a challenge, but we definitely, I see it a lot with like the medical world, and we talk about epidurals, and we talk about inductions, and we talk about home births and our stigmas in the medical system. We don't actually give informed consent, and then our families have access to the World Wide Web and so much knowledge, and then that creates distrust because you say one thing and she can clearly look up and say, well, for low-risk healthy women, home birth is a great safe option, and you're telling me it's dangerous. So I have a hard time believing the things that you are saying to me. So we have to be very, very careful of the education, the knowledge, the objective approach as much as possible, especially when we're talking about medications and alternatives. What is the data? What is the research? Is it based on a personal opinion? Is it based on good hard evidence that this recommendation is being given? In midwifery, it is crucial to have birth preferences, labor plans, prenatal screenings, and good postpartum follow-up so that we can make sure that informed consent throughout the care process is being the process of informed consent is an ongoing dialogue. It's not just handing them a piece of paper, asking them to read it, and then having them sign the bottom. We need to be able to provide clear education on procedures, on options and choices, and allow the families have time to ask questions. And sometimes it's a challenge depending on the setting, the situation, the time constraints, the knowledge we personally have about that situation. We have to really be careful when we give knowledge and informed consent that we're doing to the best of our abilities of unbiased choices and respecting the decision they make. Capacity to consent, we also have to make sure our patients, the clients we're serving, are in a place they can give informed consent. It would drive me crazy that they would get no education about their pain management options during labor, and then we're trying to educate them in good active labor about an epidural and the risk and benefits, and then it's downplayed the potential risks that are involved, and then the mom would get it and doesn't realize it doesn't take away all the pain, and now she has chronic back pain, she got a spinal headache. There were some complications that occurred. The baby's heart rate went down because the blood pressure, and then they had an emergency C-section. Like, the trauma comes from families not feeling the autonomy of they made a good decision based on true risks and benefits. It's downplayed. There's biases that are put in place that we have to be very, very careful of, especially when it's vulnerable populations, children's, babies, altered status, like if you have a grandmother with Alzheimer's and she's in good active labor transition, she would cut off her arm right now if you told her the pain would go away. So they're not in a good state of mind to make informed consent decisions, and that's why having these education beforehand about options and choices and particularly birth plans, birth preferences are really, really helpful. So challenges to informed consent, you can have language and cultural barriers. Interpreting and like I do it a lot with local midwifery. Right now I'm in the Virgin Islands in the Caribbean culture. Even Tylenol, like they're like, oh, we don't do that here. So like there's that respect of like giving choices and not feeling like we're putting a bias in, but there is that feeling of cultural difference of like, they normally don't talk to me about this. Are you bringing in your cultural perspective? Cohesion and pressure. Our society, our mom, she really wants a home birth, but her grandmother, her aunts, her support person is telling her that it's not safe and they don't support her. We have unintentional consequences from that pressure. And we always have the best intentions at heart, but we don't realize our comments, our demeanor, rolling our eyes, condescending tone, passive-aggressive nature has messages to them, and people pick up on it. So we want to be that safeguard during pregnancy on that individual autonomy and being a safe place to allow them as much as possible within the situation. Normal, healthy mom and baby, instinctual birth, normal labor process. We're there for emergencies. If the emergency is happening, we build up enough trust and relationship that we can talk about it afterwards, and there isn't the time side for the informed consent. We've really got the tools and resources in place to handle that. When you have a newborn resuscitation, you're not going to talk about the risk and benefits of immediately helping their baby out with breathing. You're just going to do autonomy and respect for choices. Like, birth is a heavy cultural perspective. I get it all the time where people leave the hospital against medical advice, or people are thinking in the clinic they're talking about transferring out and doing a home birth this time around because they weren't happy with their last birth experience. And this medical staff is so, a majority of the time is so, they'll be nice to their face sometimes, and then they're just so nasty in the backdrops. Our stigmas, our cultural biases come out in clinical care, and we have to be very, very careful of it. So I really want you to stress options and choices in individual situation. Are you high risk? Are you low risk? Like, you've had 3 prior C-sections. Here's the risk and benefits of choosing that option. Like, I wouldn't recommend a home birth for you because of this, this, and this. But if you're normal and healthy, like, maybe you are a good candidate. Find a great skilled midwife. This is who I collaborate with in the community to do that. So we just have to be really careful of allowing them choices within their care based on the risk and benefits that are occurring. Promoting autonomy, midwives are great at providing information, respecting their choices, and empowering that decision with aligned values. But sometimes, especially if you're employed at a bigger healthcare system, there may be policies and protocols that you have to first line recommend and suggest, but then just document really well they chose an alternative option, and our clients have that choice, our patients have that choice. And to protect your license and to protect your employment status and not violating your hospital privileges, you just have to document really well. Like, every patient has the rights to autonomy over their choices. The hospital may not want them to do a VBAC after 2 C-sections, but if that's really important to the patient, they have to respect it. Challenges to autonomy, medical interventions and controls. The midwives we already talked about in the last section. We feel pressure. We feel from our collaborating obstetricians to keep up that written agreement that's required with the state, that we have to do some extra labs and ultrasounds and testing and risk out criteria to keep that relationship. To have fear of complaints at the state from the hospital. We maybe transfer for our home birth center a little more conservative than we would do in another state. So you have to look at the bigger picture of choices and options given to our families based on our own constraints within our scope of practice, based on our employment contracts, based on the culture of your local community. So we always have to, it's an art to balance it all, for sure. Conflicting values, like, maybe I personally don't believe in circumcision, but if they want to circumcise their baby, you have to keep your personal biases out, and you may choose not to offer that service in your practice. You can refer them out for that. So there are certain things where you can offer them their choices, and then you can, if you don't directly want to offer that service, you can provide them with the resources to continue that. And even with breastfeeding and bottle feeding, because it may not be the best fit for everybody. And so we have to be, especially in out-of-hospital births, we're very biased that everybody should breastfeed, but there are situations where I've seen that moms just don't make breast milk, and she had a C-section, a Pitocin, and she had everything against her, and we don't want to cause postpartum trauma of her being a bad mother because she wasn't able to breastfeed this time around. And so our society pressures and our challenges and demands can be more overwhelming than what the mom ultimately wants to do, but we want to advocate and support her the best of our abilities. Our role is to provide unbiased, evidence-based information while respecting the family's decision. Shared decision making. This is a very powerful tool. It's a collaboration between the midwife, the family, the specialist, the nurses, the team that's taking care of her, so we can make the best decision as a whole versus the midwife, the doctor just comes in and says, well, this is the plan, this is how we're going to do it. Do you have any questions? That's not really shared decision making. We want to navigate those ethical challenges of balancing cultural preferences and beliefs. For example, a lot of the African cultures, they're used to not doing a C-section even if the baby is close to dying, because if the mother, especially these high-risk third world countries, there's a high probability the mom will die during the C-section. So if the mom dies, now this baby's not going to live because they have to breastfeed, they don't have formula, and now her other children won't have a mother. So sometimes these cultural preferences of like the baby is clearly dying on the monitor, and their beliefs that I can't do a C-section because they're thinking it's the same risk and benefits of a C-section in their hospital in Africa versus they're down in the United States. Those things are coming out. So we have to get to the root causes of the fear, the anxiety, the decision making to make sure we're on the same page with things. Collaboration and communication is sometimes hard during labor and pain, and everybody wants a perfect birth, and sometimes they can't get that perfect birth. 1 in 3 women are having C-sections in the United States. Part of it is because of convenience and our health system and our families all wanting social inductions and don't really understand the risk and benefits of all these inductions when the body's not ready. The list goes on and on and on. So shared decision making really you need to have active listening, clear communication, mutual respect both directions, and not have time constraint pressures in our authoritarian biases in place. So we need to facilitate discussions on risk and benefits, alternatives, educational handouts, giving them some time to think about their options so they feel confident in the decision they're making, especially the more complex the situation is. You have an anatomy scan and now this baby is incompatible with life, and some people's decision are going to be an elective induction and termination of the pregnancy, and some people's beliefs are going to be, I'm going to continue to the pregnancy, I'm going to have a normal natural delivery, and if the baby only lives for a few hours, a few days after the birth, we're going to respect that birth process and our God's beliefs and our Christian values or whatever direction they're thinking, and we have to respect them either way. Balancing medical recommendation and autonomy, especially in obstetrics, we're advocating for a baby inside of our mothers that doesn't have a voice, and we're trying to balance the risk benefits to the mother with the risk benefits to the baby in the situation. And so it is a challenge, and sometimes hospital ethics gets involved. Sometimes midwives risk out their clients because there's extreme viewpoints and beliefs. Like, I've had such home birth clients with such severe birth trauma from their last deliveries that they could never make informed consent because their personal biases of, I will never go to the hospital again unless I'm dying, that will not align with a team shared decision making with a home birth. And if we need to transfer and if we need some additional medical assistance, this mother is not going to be a good candidate for that shared decision making. So we have to really have good discussions at initial consults throughout the pregnancy. Some of these decisions, because you're already in the hospital setting, they've got access to all those resources. But when you're doing birth center at home, you need to be able to trust each other. You don't want them to hide in their history something because they really, really want this home birth center delivery. And if you knew about something in their care, that would change that criteria. So getting prior records, being able to have trusting relationships with the families we're serving is So ethical dilemmas, we need to navigate between informed consent, decision-making, autonomy, especially high-risk situations and complications during pregnancy, because she may not want to have her baby now, but she's in preterm labor, her water broke, her blood pressure's high, she's really sick, and the only way to get her better is to deliver the baby, and the baby may not be ready to come out. And so you're always in this art of a challenge of every day getting steroids, getting antibiotics on board. The mom may seize with preeclampsia and become eclamptic, but we need some time for the baby so that the lungs mature and the baby can be ready for the outside. So it's a challenge at some of these gray zones of balancing what's best for the mom and what's best for the baby. Emergency situations, shoulder dystocias, non-reassuring heart tones, postpartum hemorrhages, the midwives need to act without really giving informed consent. They just need to say, I need you to turn on your side. I need you to take some slow, deep breaths. Your baby's heart rate is low. These are some of the things we're doing. We're going to prep for a C-section. We're going to transfer to the hospital. And they trust the knowledge and skills you have to handle those emergencies, and then you can talk about it afterwards to get clear understanding. But there are situations with inductions and risk benefits and what a healthcare provider may recommend. Like, we just recently had a lady that ruptured at 31 weeks, and the standard is to have her stay in the hospital till 34 weeks, watch for infection, get her steroids, but it's a financial challenge. She doesn't have insurance. She's not from the United States. The costs are getting really, really expensive that it's going to bankrupt her family to make the decision to stay in the hospital longer. So she has to make, as a patient, the decision of, okay, do I bankrupt my other kids and my spouse at home so that we can spend hundreds of thousands of dollars and weeks in the hospital to give this baby inside of me some extra time? And so there are some states that have support social resources, but don't always make the assumption there are those options, because healthcare is very, very expensive. Some states you can accelerate the Medicaid financial assistance program, and some places you can't. So like, I'm in the Virgin Islands, and there's a lot of people that would come from Haiti, Dominican Republic, the British Virgin Islands, because they want their kids to have U.S. citizenship. They get on a ferry and come here, but they have to pay for their services. They're not on Medicaid. They're not a U.S. citizen. So there's definitely some challenges of like providing care in EMTALA and challenges with financials. So there's just a lot of things with religious beliefs, Jehovah's Witnesses, if they're bleeding out and we have blood products available and they won't accept them, we have to respect their religious viewpoints. With the Amish Mennonites, they take their babies home, they take their mothers home if there was a bad outcome and a mom and baby passed away. They don't embalm, they do the delivery. Like, I can tell you as a home birth midwife, the one and only death I had right out of midwifery school, the baby passed 6 hours after delivery, and I drove the Amish mother home with her dead baby in her arms. And having respect, the emergency department and the services of the community, because there's so many Amish Mennonites, have a huge respect of their beliefs and their culture. They don't do autopsies. They don't do the traditional things we're used to in our English society. So it's really powerful to see when you get communities that do good informed decision making and respect the cultures of their patients they're serving. It just goes wonderfully versus the authoritarian, this is the way we do it for everybody. The threats, the biases that just come out in care really cripple informed consent. So as a conclusion, ethical dilemmas in midwifery and just in obstetrics as a whole have to balance the situation, the shared decision making, the knowledge that person has, the time constraints, the cultural beliefs, the financial challenges, the whole situation. It sometimes is a tough art, but we have the advantage as midwives. We build up trust and relationships. We typically have time on our side with prenatal visits. We are typically a small community midwife with 1 or 2 people in the practice versus there's 8, 10, 12 providers, and this person is just a number. They don't remember you. They haven't built that relationship. So we do have advantages as midwives. We get a deep relationship with our clients and patients we're serving, and we just have to be careful of balancing that professional judgment, our own biases, and really being able to offer them the best situation for them and respecting the decision they make. So open communication, mutual respect are and trust are true key factors with ethical, patient-centered care.